All right, we're good.
Okay, this is a patient with Budd-Chiari syndrome, and I'll show you some clinical information in a moment. But she has antiphospholipid antibodies. This is a chronic condition, and right off you can see she's got liver disease, of course, ascites, and she eventually got a stent, a TIPS or DIPS stent. But I'll show you an interesting thing in the lower chest on the abdominal CT, because we haven't imaged her chest, as you can tell, for a long time. But there's some interesting findings in the chest on the lower abdomen. And let me pick out one from August of 2019. So already back here, you can see that she has a lot of superficial abdominal wall and chest wall collateral vessels. And with Budd-Chiari, of course, a large variety of collateral pathways have been described to get blood back to the right side of the heart. And here we can see that these superficial chest wall collaterals are very large and very conspicuous. So here are some even intramuscular related to latissimus dorsi adjacent muscles that are large. And here we can see large paraspinal collateral vessels as well. So those are very conspicuous. So let me just mag this up a little bit and try to show you places where one can see that these chest wall collateral vessels, particularly these down here, are going towards the chest, and there are some locations where they are clearly penetrating into the chest. So let me just switch over momentarily to the CT to show you that there are places like here where there are dilated vessels in the peripheral portions of the lungs. And as I scroll back and forth, you can see that those vessels do communicate with pulmonary veins. So again, let me show you, there was one location on one scan where by virtue of timing, these vessels, at least down here, were rather nicely opacified. And I must admit, I can't remember which scan showed those really nicely. But this is certainly consistent with communication of these veins with pulmonary veins going to the left atrium. So certainly we've seen communication between veins of the chest wall and pulmonary veins in the context of central venous obstruction in the chest, particularly, for example, SVC. But this is one undoubtedly occurring in a patient with Budd-Chiari syndrome. And what's interesting is that you can see from this note here that there are findings consistent with the communication between systemic vessels and the left atrium. So they wondered about there being AVMs. So this is not the hepatopulmonary syndrome, but this is a case of communication between these veins and pulmonary veins that account for these ultrasound findings. So I looked under Google, and while you can find lots of articles that describe alternative pathways, I didn't actually find one that describes communication between, for example, chest wall veins and pulmonary veins. But I'm pretty sure we have it here, both morphologically as well as a nice explanation for this finding right there. Anyone seen that before, potentially?
Have not.
No, not like this.
Yeah. Do you agree with the findings? I think I can, that
Yeah. Sorry, yes, I was
yeah,
muted.
I think that,
Agree.
yeah, I tried to find one. I had one in which there was some really nice enhancing vessels right in the basal chest, but I can't find it right now. But look how big these vessels are. So yeah, this is
Impressive.
really interesting. Yeah. So Budd-Chiari with that phenomenon. Here is an interesting patient that shows the evolution over time. I'll show this to you. I'll withhold some information just for the moment. So here is a CT that is before surgery in 2017, and the patient had liver transplantation. This next one I'm going to show you is from 2018, and there are findings of liver transplantation. You can see the usual surgical clips there, but I will show you, and this wasn't really picked up, but not surprisingly because it's a really small finding at this time, but there is a small new focal defect of left hemidiaphragm containing a small amount of fat. And that's in August of 2018. Alongside, I will show you about a year later that the defect is a little bigger. There is a little bit more fat in there, and there's also a little bit of fluid associated with that in September of 2019. And now alongside that, I'll put up an exam from this April, showing you again that there's the defect, but now you can see that a portion of the stomach has gone through the defect into the chest. There's a bit of fat there, but gastric fundus is in there. And the patient was symptomatic there, but became even more symptomatic just in a short period of time. So here is the next day. And you can see now that we have a complication of the herniation of the stomach. So there's more opacity related to the fat. There's fluid in there. The stomach is trapped in. There's more pleural fluid there. And the patient was very symptomatic at that time. So here's the op report. We have an incarcerated and ischemic stomach. Here you can see excerpts of the op report. They identified a very small hole, they said, 2 to 3 millimeters in size at the time of surgery. They fixed that. So just really bad luck. I think at the time, undoubtedly, of hepatic transplantation. I'm not sure why on the left side that little diaphragm defect was caused, but then you can see ultimately a complication of it there. I think that's by far the most plausible explanation, because there was no surgery on the left side per se. So the small defect became pretty important, quite impressively so.
Yeah, that's a really nice case. You know, I have a similar one that I showed a couple years ago that was on the right side after a liver surgery with incarcerated, I think it was colon. I may try and pull it up just to show it as a companion for yours.
Yeah, it's pretty scary. Let me show you one more. So this one is a patient that came in with a gunshot wound or gunshot wounds to the neck. And you can see he was intubated, he's got a gastric tube. You can already see we have abnormal soft tissue air. We have abnormal opacity in the apical left hemithorax. We have abnormal opacity in the left supraaortic mediastinum. Lots of findings consistent with a gunshot wound involving the lower neck in particular. I'll show you a CT of the chest. So let me just get my timing right, which was done a bit later. And here we go. And you'll see there's soft tissue gas. Now, patient's intubated. And this is a situation in which, I know Travis has shown this before, but it's really easy to go by a tracheal injury. First, let me just give you a feel for how much fluid and blood is present at and above the thoracic inlet and below the thoracic inlet into the mediastinum. But I want to go back to the trachea. So look here where The trachea is round in configuration, but right here is one location where there is a slight marginal abnormality. So now instead of being quite round, it bulges just a little bit there. And that's small, but it turns out to be an injury. So one has to be really quite careful in evaluating that. It wasn't called in the chest CT. Kudos to the neuro folks who read the neck CT. And among other things, they did describe this finding. And here I'll put in excerpts of the op report. But you can see here from that they were able to fix this left posterolateral tracheal wall injury, which again, undoubtedly corresponds with this right there. So I know Travis has shown something like that before, but this is a hard area. But of course, you have to have a high index of suspicion when you have such a bad injury. And bullets have gone by that area, right there. All right, so a direct injury to the trachea and adjacent structures from bullet wounds. Those are my cases, Jeff.
Okay, thanks. So who'd like to go next?
Jeff, I can go.
Who is that? Sorry.
Seth, you can go ahead.
Hey, are you getting some crazy feedback thing?
Tracheal injury.
Oh, Howard, we're hearing you.
I don't, is it me? I can
No,
mute
I
myself.
can not. Okay, sorry about that.
But I'll mute myself.
All right. Want to try again, Seth?
My cases aren't ready yet, actually. It wasn't me saying it.
Peter, you want to go?
Sure. Go.
Which again, tracheal injury. Which again.
Okay. You guys see the screen?
Yeah, we see your screen.
Okay. So this is a 31-year-old patient. I'll just give a quick history. He has bicuspid valve, which was repaired in November at an outside institution. He's a construction worker, so they repaired him with a bioprosthetic valve because he was kind of a high risk for falls, and they didn't want him to be on Coumadin. Well, unfortunately, his bioprosthetic valve dehisced, so then they had to go in and do another sternotomy, and they did a Bentall procedure where they replaced the valve and the aortic root. And then after that, that got infected also. He had sternal dehiscence, and they repaired that from what I read from the outside institution. But then he came into one of our sister hospitals 2 days ago, not feeling well. So this is this CT presentation. This is one of the worst, might be the worst case I've seen of graft infection. So if we start off from the LVOT, there's severe dilatation here, and you can see the bioprosthetic valve is dehisced from the annulus. There's this gap here around it, and then you can see contrast as you go up, contrast leaking around the graft into this space here in the mediastinum surrounding the ascending graft. And here is a mix of fluid and peripheral enhancement and contrast. And you can see contrast leaking all the way up into the sternotomy site here. And a lot of lymphadenopathy and just some edema, interstitial edema in the lungs. So that's one of the worst cases I've seen of graft infection. Unfortunately, this patient left AMA shortly after he was admitted. So he was scheduled to go in for surgery, but he left AMA. So I don't have any follow-up.
That's pretty bad there.
Yeah. And unfortunately, on my connection, I'm remotely logging into our Cyrix, so that kind of froze.
Yeah, I see.
Somebody else, why?
Okay.
Maybe show some cases.
I can show some real quickly. Let's see. Where's my Osiris? There we go. Okay. Let me make myself presenter. Share now. I still don't like this new interface. Here we go. Share screen. Okay. You see feet. All right. So this is a patient who has thromboangiitis obliterans, also known as Berger's disease. And I guess I'll start with this older. This is an older abdominal scan. You can see if we go down, the infrarenal aorta is pretty much out. There's a little flush of contrast there. And then you see a lot of collaterals in the abdomen. There's stents in place. They look pretty bad. But then as you go further out, there's reconstitution. The external iliac on the left is gone. But you see reconstitution through the chest wall, primarily body wall. And then, going down the lower extremities, it looks pretty good. And then we get down to the bottom. The left foot looks kind of start losing some arterial supply. So there's good three vessel runoff on the right, but on the left, you can see they start fading out. And then we see just a little bit of flow down there. So this is a chronic condition. So that was an older scan. Patient presented for chest imaging to rule out PE and doesn't have PE. But what's interesting is you can see he does have LVH from all the high pressure from increased systemic vascular resistance. The RV looks a little thick too. So that I don't know if there's some microvascular involvement, but to my knowledge, that's not a common manifestation. He's a young guy, I should add. He is a smoker, as most of these patients are. But what was nice is one of my colleagues picked up sort of the bottom of the study here. There's this new parenchymal defect in the kidney on the left, and you can see so a little renal infarct there, and I can't remember if there's one on the other side. Yeah, right there on the very end, you can see a little cortical defect, and those weren't there on the previous one. So Berger's disease or thromboangiitis obliterans with some end organ damage and kind of an interesting cardiac finding of pretty severe LVH from that. Let's see, another interesting case. So this is I have two esophageal cases. They're pretty quick. So this is a good case for trainees. You see a patient with a dilated esophagus. There's a fluid level in it. So clearly some motility problems. And if you saw this on an exam, one of the things you think about is achalasia, pseudoachalasia. In this case, I think it's more iatrogenic, but you can see this patient has this device, and I'll show the radiograph, and has also had gastric bypass surgery. And this device has a reservoir and this little silicone ring, or this ring that goes around sort of the esophagogastric junction, and it shows best on the lateral chest radiograph here. And then you can see the ring here. So this is a LapBand, and it's used primarily. It was used to try to treat obesity. It actually works somewhat as an anti-reflux device. It's not great. But in this case, it's causing enough obstruction that the patient's retaining liquid. So if they reflux, they can't clear it effectively. So it's sort of a pseudoachalasia caused by a LapBand. And then this last case is just kind of something interesting. So this patient had a young female, 35, had a previous gastric bypass, and then had developed an internal hernia and a hiatal hernia, and underwent laparoscopic repair and presented about 5 days afterwards with just severe abdominal pain, just not being controlled by our usual measures. And what was seen on this outside CT is just a ton of the simple appearing liquid around the esophagus. You can see it doesn't have an enhancing rim. It's not, the fat around it looks pretty good. It almost looks like a thickened esophageal wall, but if you look carefully, you can sort of make out the mucosa and see that the wall of the esophagus is probably here. They did do a esophagram. There was no gas or anything in the mediastinum that showed it was perfectly intact. This is what it normally should drain like. This is actually a nice image showing the normal drainage here. We don't see any mucosal irregularities, no extraluminal contrast. And of course, this is the gastric bypass here, the Roux-en-Y. So it was just presumably simple fluid that had been in the hernia space. I don't have preoperative imaging, so I don't know how big the hiatal hernia was. but that can occur. I think we just don't image these patients so soon right after surgery because we don't have a reason to do that. So just some simple peering fluid. So she was discharged home with a little bit better pain management, but you know, and nothing pointed towards a leak or anything. I don't know if anyone else has ever seen this before. I hadn't seen it before, but again, we just don't image the patient typically after routine surgery.
Scary looking, but
yeah, it is. Yeah, but I think that the things that make you feel good about it is, you know, what you see the rest of the mediastinum is normal. You know, you don't really see a truly thickened esophageal wall, and it's very homogeneous. So, all right, Peter, are you back online?
Yeah, I got two.
Hey, Jeff, can I ask you a question about 2 cases?
Yeah, absolutely.
On the LapBand, can you go to the AP radiograph?
Yeah, I do have it.
Just wondering what does the phi angle look like on that? Can you see the LapBand at all on there?
Not real
well. It's maybe like
Yeah.
it looks like it's probably like 45 degrees.
Maybe in here.
Yeah. Okay. So yeah, not too crazy. And then the other one,
if it tilts more, the angle's more acute, it sort of kinks the esophagus.
yeah, it should be between 4 and 58%, 58 degrees. And I wonder if you could probably see it well on, like, if you made a coronal recon of the belly or chest. But yeah, it can erode into the esophagus if it slips, or it can cause obstruction.
There you go. Yeah, it looks like it's about 30 degrees, maybe 45.
That's right.
There it is, right there.
And then the other one, so that the guy with the thromboangiitis, is he a heavy smoker?
Yeah, he's an active smoker. I think he's only a pack or pack and a half a day, but yeah, I mean, he's still smoking. That's the first thing I looked up.
And there's a complete occlusion of the aorta. That's like, what is it, like Lariche syndrome or something? How do you know that he's not just throwing emboli from there into the lower extremities?
Well, that abdominal CT is older, you know, because you can see it's out, and then he's got the stent graft here that is occluded. I mean, presumably that's what is happening distally. I don't know. He doesn't. I mean, this was the renal infarct, so I don't know if he was throwing clots to the kidneys on the CT. This is the abdominal CT. You can see even on this older scan, he's got micro probably infarcts on the periphery there. I should have showed those earlier, but he's got these little cortical defects. But they got a lot. You can see these were, so that was them a year before on the abdominal CT, and then on the chest CT, if I go down, you can see that they're much larger peripheral defects. It's not as dense of a contrast bolus, but you can see there's a whole area here. Yeah, I don't know.
I mean, more in the lower extremity.
I mean, I remember this. The only thing I remember about this disease is the classic hand angiogram you would see on the old board prep stuff. You know, it was the classic history as a male smoker, and you could see just the sort of occluded small arteries in the extremities. But yeah, he just took out the whole mid aorta there. You can see there's no contrast as far down as this goes. But what's kind of interesting is he's got a lot of intramuscular arterial collaterals. So in the rectus sheath, for example, he's got all these nice vessels, and even some of the intercostals are a little juicier than we typically see on a chest CT. Okay.
Yeah.
All right. So Seth, you said you're right. Peter, is your connection back up again so you can finish your case, or?
I think it's up, yeah.
All right. I'll make you your presenter, then we'll go to Seth.
Okay, should be pretty quick. Okay, so this patient, this is just kind of a quick show and tell. This is a middle-aged patient, no past medical history, comes in with heart failure and troponin elevations, chest pain, and he got a preoperative CT, and you'll see why. So you can see the heart the LV is very dilated, and he has this abnormality here. Initially, I wasn't sure if this is a vegetation or a mass. Turns out it was just a very large vegetation on the mitral valve, probably the largest one I've seen. And he was bacteremic. No IV drug use, but the only relevant history was that he had dental work done a few months ago. And the bug was Streptococcus mitis oralis, which is actually the second time in the last few months I've seen that bug cause endocarditis, infective endocarditis.
Wow, that's huge.
Pretty huge vegetation, yeah. Yeah, with a lot of mitral regurgitation.
Almost looks like a myxoma. It's so big.
Right, yeah, and that's the first thing I was wondering is when I first looked at it, I opened this without looking at the chart, and I thought this was either mass, maybe myxoma growing through.
Was he? I may have missed it, but was he throwing any clots anywhere that?
I didn't see any. I didn't see any evidence.
Okay.
I think his brain MR was normal. I guess, is it possible that he could have an underlying myxoma that just got vegetations on top of it? I'm not sure.
Yeah.
But maybe I'll follow up after the surgery.
Yeah. But usually you can.
Or if it was just.
Catching.
Yeah, if it's just a prolapsed, like degenerated mitral valve. So
Yeah.
a little thick in other areas and a little redundant.
Yeah, maybe. Yeah. Yeah, I'll follow up on the surgery and see if there's anything interesting. And then the last one that I have is kind of coincidentally, it's kind of a companion case to what Howard was showing, but it's not the exact same thing. But it is stuff that you guys have shown before, so I don't know if anyone will be impressed. But this was a patient with this was evaluation for pancreatic cancer, evaluation for metastatic disease in the chest. Here is this big pancreatic head mass. So the impressive thing that the interesting thing I saw are these vessels right here, and they're highly attenuating, kind of similar attenuation to they're obviously opacified with contrast, similar attenuation to what's in the LV and left atrium. And if you follow them, actually, you follow them up, they are draining into one of the inferior left pulmonary vein. And then furthermore, you can see here, there's another paraesophageal varix, which is emptying and mixing contrast with this vasculature here. And then so I was wondering, so these, I know I've seen, and you guys have shown portal to left atrial fistulization, but I was wondering why this patient, he doesn't have, why would he have portal hypertension? His liver looks good, spleen looks normal. And then I went back to his 2007 CT. You can see much more profound paraesophageal varices. And then, so it turns out he had a history of cryptogenic cirrhosis, and that he got liver transplanted at some point and developed pancreatic cancer. So this is a good example, I thought, of portal to pulmonary vein fistula.
He's also got potentially an interesting liver lesion near the anterior right hepatic lobe. There's some vessels that seemingly are penetrating there, maybe part of some collateral pathway as well.
Yeah, possibly, yeah.
That's really interesting, yeah.
There are some rare, weird tumors that enhance like that of the pancreas. There's one called, I think, a hepatoid carcinoma of the pancreas, because that's pretty bright for a it's not quite bright enough to be an islet cell, but maybe that's because it's just so large that it's necrotic, but it doesn't look like an adeno there.
This right here, yeah.
Yeah. Huh.
Yeah, I would ferret. I mean, you'd almost wonder if that could be even an HCC met back there if he had cirrhosis previously, but yeah, it looks hypervascular, maybe an islet or
follow up. Actually, I'm not sure if they've biopsied or anything, but I'll follow up. That's all I got.
All right. Let's see. Let's go to staff now. All right, Seth, you should have control.
Yeah. Okay. So this is a weird case for I wanted to show for one main reason, but this is an odd case. You know, this is a adult patient, 30s, comes in. We're still not really sure what, we had a debate about what the underlying anatomy was for the repair. You can see there is what looks like a core tracheatum here, where you have, but what's weird about it for me to be a core tracheatum is that all of the pulmonary veins go into this kind of separate little atrial segment, which is weird for a core tracheatum, unless it's the most severe core tracheatum ever, which is possible. You know, my thought was that it was actually a TAPVR potentially, where they then repaired it, and I thought that they might have created a kind of a second, you know, this is either tissue that's been kind of, because initially I thought this was actually the normal septum here, and what I thought they did is it created a kind of a barrier here that kind of partially calcified and then redirected flow from this segment back into, you can see it's this very calcified area back into the left atrium. I don't know. I don't know if it was just a core tracheatum where all of the pulmonary veins drained into the posterior atrium and the patient was kept alive with an ASD, or if it was TAPVR with a correction. But that's not why I'm showing the case. As you can see, the now all the pulmonary venous flow is directed into kind of directed into the left atrium. Sorry, this is backwards. I know but this is that pulmonary veins, and it's going through this very small little opening. So you can imagine there's some pretty impressively elevated pulmonary venous pressures, given that all the pulmonary venous flow has to go through this small little opening. On top of that, you can see that the IVC itself is dramatically narrowed in its opening into the right atrium, and the opening of that is also somewhat medialized. You can see it here, a very, very small opening. So the reason I'm showing that is you can see that the actually pulmonary veins are just diffusely calcified. You know, I've seen, you know, we've all seen pulmonary arterial calcifications, and I think we've all seen pulmonary venous calcifications near the ostia due to prior therapy, especially ablations. But I've not seen pulmonary vein calcifications before to this degree. So these are, you know, acquired pulmonary venous calcifications from dramatically increased left atrial pressures due to this, you know, strange correction of some unclear congenital heart disease. And the issue is not, you know, people are like, oh, you know, a patient has passive hepatic congestion, IVC is quite dilated. Most of the flow from the belly, we have a different phase of contrast, is in another portion of it I didn't show, is all going through the azygous and hemiazygous system. So it's almost acting like a azygous continuation. The issue is that because of this severely elevated left atrial pressures, you're getting dramatically increased, you know, right-sided pressures, big, huge PA, huge RV. So now you're basically having secondary obstruction to all pulmonary venous or systemic venous return, which is now basically going through the SVC because of that. So anyways, they were going to take the patient to surgery, but she left AMA. So we'll never know probably what happens to her. This is a case that someone asked me to look at yesterday. This is a patient with some form of cutaneous T-cell lymphoma. Not sure why she has such bad atherosclerotic disease. She's only like 50 years old. But if you're scrolling down, it could be missed. But you can see that there is a very interesting hole in the posterior portion of her trachea. they're not really sure if it was a stenotic or a intubation injury. They're like, the cuff was never really overinflated. I could try to do some 3D recons, but it'd be a waste of time. You can see there's this big gaping ulcer, and they said literally when they went in, they looked at it and it was just a big hole. And here are some pictures. So you look at this, and I'm like, what, is there a mass there? Like, no, that's the esophagus actually just flopping into that huge defect. Here's another picture where you can kind of see the tracheal cartilage. So here are the tracheal rings anteriorly, and then through the membranous portion, there's just a big hole, and the esophagus is prolapsing through the hole. And then she has pneumonia. It looks very airway center, kind of aspiration-y to me, or at least, but she doesn't have a fistula between the esophagus and the trachea. So I'm not sure why that happened per se. Maybe it preceded or they're unrelated. The third case is.
And Seth, there's no history of remote radiation therapy for any reason?
No, she never had. She has cutaneous T-cell lymphoma.
Okay,
so I don't think she's had radiation. I don't see any evidence of, maybe she does. I just don't see striking evidence of paramediastinal injury. I didn't get that from the history, but I'll have to double check. This is a cute chest X-ray. I saw this chest X-ray, and sorry, this is just that. That's the pneumonia detector one. So this is an older gentleman, and initially I thought this was just going to be prominent SVC like we see in a lot of older gentlemen. You can see quite a tortuous aorta. It looked a little big down here. Didn't really catch my eye, but I was wondering maybe if there was something on both sides. It's hard to tell. But what was interesting is I noticed that there was some calcification here, which would be strange for the SVC. And this was quite a large structure. Still thought it was just maybe calcification of the brachiocephalic, but it was really pronounced. And the patient had an old CT from the outside. And I mean, we've all seen this before. I've just never seen one with an aneurysm. Is this the right patient? Sorry, wrong patient. That big. So this is just a, aberrant subclavian, but it's just a really big aneurysmal aberrant subclavian artery. I don't know if I've seen one with that much atherosclerotic disease and get that big, but that's what we're seeing in that kind of right paratracheal stripe region. It's just this very large aneurysmal and extensively calcified aberrant subclavian artery. Unfortunately, we don't.
Seth, I saw one in fellowship, and it was that big, but he was a really large patient and kept refusing intervention on it. And actually, I think like a day or so before he finally decided to have it repaired, it ruptured. But it was bigger than yours. I don't think I was able to save the case at the time. It was a long time ago, but yeah, and it was like yours. It was strikingly atherosclerotic with little disease. I mean, yours has more disease elsewhere. It looks like
he has this aneurysm distally,
but
and again, he's like a 78-year-old guy.
Yeah, my guy was younger. He was I think he was in his 30s or 40s, but even then it had some atherosclerosis, probably because it's just extreme turbulent flow there.
Yeah.
So, Seth, can you go back to the plain film?
Absolutely.
Because
I really would have liked to have a lateral on this guy, but no dice.
Even without the lateral, you can also see the left wall of this thing going up. So
yeah,
you're seeing that's the right wall, but if you look at
the arch,
left wall coming off the aortic arch. Can you? I wish I could. Yeah, right. So that actually, I think you could make the diagnosis, and that's calcified too. You can make the diagnosis on the PA view here. You can see both sides of the lesions.
Yes, a better eye than mine on plain film. Absolutely. That's yeah, you're right. No, that shouldn't be. You're 100% right. That shouldn't by any means be there.
Just a bit lower. Yeah.
So the calcification, I've also read, as probably everybody else has, that this is not normal aortic tissue to begin with, since it's a remnant of tissue that's supposed to regress in utero. And on our young patients that have even small diverticula of Comerl, they'll resect them, just because of the risk of aneurysm formation later on.
But have you seen many? I really have not seen many with an aberrant right. I mean, the right arch with the aberrant left, we see it all the time. Those get huge. But I just had not seen one.
No, only a few.
And I don't know why that is, because you're right. It's not supposed to be normal tissue, but it should theoretically degenerate in a similar way. And what the other thing that's striking, as you kind of mentioned, is that the atherosclerotic disease really does, or the aneurysm really does immediately end right at the bifurcation where it divides into the carotid and the subclavian. So I
think part of what promotes the atherosclerosis here is the thing comes off at a funny angle, and it's sort of bent. As the aortic arch elongates and rises up, it forces a structure like this to buckle, and that funny shape leads to turbulence, and that promotes atherosclerosis.
Yeah, I'm sorry. It's actually just I did not break the common carotid, but right where it kind of goes out the thoracic inlet, it kind of immediately becomes normal, and there's no disease anywhere else, and all the other arch vessels are normal. Anyways.
Yeah, it's atherosclerosis and intraluminal thrombus, right?
Intraluminal thrombus, yeah, definitely.
Yeah, heart disease. Cool.
Which case is this? So that's the same case. Lastly, this is just a case where one of my younger faculty made the appropriate diagnosis for the patient, but it was kind of interesting, accessory diagnosis. So this is a patient who had massive stroke, and I'll just show really quick the head CT, and had massive stroke. Probably had some chronic stroke as well, but this was an acute MCA occlusion. Additionally, came in not only found down, but also had cold extremities. And you can see that there's no flow in the posterior tibial, and I'm sure there's other vessels that don't have flow. You can see the absence of flow in the iliac going into the femoral, and the CT shows what you would expect. I think I might have not included the delay, but there is a nice thrombus sitting there in the left atrial appendage. But the other thing that was interesting, which he nicely noted, was this lesion sitting here, which he also thought was thrombus, which is definitely possible, but this thing is sitting right at the region of the fossa-ovalis. I mean, it could have theoretically, maybe a patient had a PFO and the thrombus went through the PFO, and that's just a little bit that got stuck there. It's still possible. But whenever you have a kind of rounded ovoid lesion in the region of the fossa-ovalis, you should also potentially think about a myxoma. And here's the echo, and 1 second, we'll clear up in a second. And you can see this thing kind of bounce. They said it wasn't a high quality study, but bouncing around, very mobile, sitting right in the region of the fossa-ovalis. So they're not really sure what this guy has. Other major problems, obviously. They're not really sure 100% what it is, but they really thought it looked like a myxoma on echo, and I think on CT it's probably going to be a myxoma. So just an incidental, excuse me, myxoma, probably myxoma in a guy with a massive left atrial thrombus and embolization. And those are my cases.
All right. So we've got Travis and David. And Brian, if you have any cases.
I don't have any this week.
You can let Brian go.
Brian, you have anything this week?
Yeah, I got 3 cases.
Awesome. All right.
All right.
There you go.
All right. Oh, how do I change my screen to different? I'm gonna hit stop sharing. I'm sharing.
Yeah, and then you just pick.
Okay. There we go. So this is it's a case of an anomalous coronary. It's one of the, I don't see this one super often. I saw this case yesterday. So here's the left main, and you can see a nice juicy circumflex coming off of it. But the only vessel that's kind of going within the left anterior ventricular groove is this small guy right here. which is probably a little septal perforator, and it kind of peters out to nothing. Then the RCA has an early bifurcation. Here's the right coronary ostium, and it gives rise to the normal appearing RCA. And then this vessel, which courses between the aorta and the RVOT, and then forms the LAD, which is a pretty large vessel, wraps around the apex and supplied to PDA. And on reformats, you can see really nicely that this is located below the pulmonic valve, but above the aortic valve. So this is a good look for a transeptal course of the LAD. You can see that also here on the short axis, left ventricle reconstruction. Here's the right coronary cusp, and then coming off of it this way, here's the LAD traveling probably within the membranous portion of the interventricular septum. Next up, this is a case that came in last night. It's a 64-year-old sudden death in the field, resuscitated with CPR. The chest radiograph, not really that remarkable. They got a CTA PE to assess for a cause of sudden cardiac death, and no PE, but the overnight resident very astutely pointed out that there's a little too much tissue around the aortic arch here, and if you look closely, you can also see some medially displaced intimal calcifications. This fluid over here, which measured about 30 or 40 Hausel units. So they recommended a CTA arteriogram. And on that, you can see really nicely that there's a large intramural hematoma. It starts around the level of the left common carotid artery ostium, extends all the way down into the abdomen, and some intramural blood pools here. A little lower down, there's also probably an ulcer-like projection. Yeah, I think right about here, you can see there's a little break in the intramural hematoma with likely a direct communication between the pool, the contrast filling the wall of the intramural hematoma and the aortic lumen. And the patient also has probably some pulmonary edema related to the resuscitation. And then the last case, this is a...
What's funny about that is that why did the patient, do you think the patient in the field arrested? Because yes, there's pathology there, but it doesn't seem to be something that would produce some kind of cardiorespiratory arrest per se.
Yeah, I think they had an arrhythmia, and I'm not sure exactly what led to the arrhythmia. I don't think the ascending aorta is involved. I wonder maybe it's just increased afterload on a poor ventricle, if that could have led to it, but I'm not sure.
So is there any chance that that it was resuscitation that led to this aortic injury here?
It's a great question. Could be. Yeah.
You've got a pneumo, you've got a chest tube. It's peculiar.
Oh. Yeah. Yeah, so like a primary arrhythmia and then the resuscitation. I haven't seen any dissections or intramural hematomas from just CPR. They do have a lot of rib fractures. I don't know if anyone's seen that before. Yeah.
Do you think, is there a sternal fracture too, or is it? Sternum looks irregular, but
not that I saw. Let's see the central. Not that I can. Oh. No, not that I can appreciate. Not really.
Okay.
I'll take another look later.
Okay.
And then the last case. This is a kid with of Arabic descent with these pulmonary artery pseudoaneurysms. You can see there's some layering thrombus within them as well, and some associated change in the lungs as well, distal to some of these. And the interesting thing also on this is, here in the right ventricle, there's a big thrombus here. And so I didn't know this beforehand, but apparently there's a 3 times higher prevalence of factor V Leiden in the Behçet population compared to the general population. And this kid has both Behçet's and factor V Leiden mutation.
That's a cool case. That's a really nice case.
Is it just the same genetic? Are they just? I mean, they're two separate.
Are they related?
I mean, yeah, because the Behçet's is, I forget, some HLA type, and
yeah, I don't know what the kid's HLA status is. It's a 17 or 16-year-old. But they do have both. Yeah, I'm not sure how they confirmed it, but
wow.
Yeah, they're treating, I think, with, I guess, the systemic inflammatories they usually treat with.
Yeah. Usually with Behçet's and pulmonary vascular involvement in males, it's not usually a good prognosis. That's an amazing case.
Wow.
Yeah, no, that's one of the nicer Behçet's I've seen. It's pretty.
If you go to the lung window right there and those smaller vessels in the right lower lobe, are we seeing some hemorrhage or something? Something's wrong. Are they leaking or what's happening?
Oh, you're talking about the parenchymal findings? I think maybe I'd kind of attributed it to maybe just some embolization, but or I guess maybe hemorrhage.
Maybe looks like blood to me.
Yeah.
The pulmonary artery to that area is occluded, right?
Yeah, there are a few different areas where there's small and large occlusions.
So we may have ischemia to the lung as well.
He's got lesions on his lung too. Yeah.
Here's the PA totally out right there. Let's see if I can pull up the coronal.
Gosh.
Yeah, it's out right there.
That is an extraordinary case. There's a song about that. You've heard that song, Amazing Case, Amazing Case.
All right. That was your last one?
Yeah, that's my last one.
Perfect. All right. Travis, do you have any?
Sure, I'll show some quick ones.
Yeah, it's time for a few.
Yeah, this is an oldie. Well, not that old. It's a couple years ago, but I just pulled this one up since Howard showed his case of left-sided diaphragmatic defect. This is normal chest radiograph. It's actually a preoperative screen before this lady was a donor, a liver donor. So she underwent a partial hepatectomy as a donor, and then came back in with abdominal pain. And so this is I don't know, this is a few weeks post-op. We don't have any imaging in between. You can see now there's new colon bubbles, not where they should be. And it doesn't look like the diaphragm is elevated, because it just looks like there's stuff here. So they did an abdomen and pelvis CT, not a chest, but you can see that similar appearance on the scout, and she has dilated loops of small bowel and then dilated loops of colon. And there's a little bit, I think probably transverse colon here, but very much the same as the case that Howard just showed. And I'll just go straight to the coronals. So I don't have the evolution like Howard nicely showed, but it looks like a little mushroom cloud here with this small little diaphragmatic defect that was presumably iatrogenic during her donor hepatectomy. And then it's just this one loop of bowel near the hepatic flexure that was incarcerated. Same thing, there's a little bit of surrounding inflammation in the fat. And so she was, again, over the course of a day or so, developed these symptoms and then quickly went to the OR. And you can see the decompressed colon beyond that. So another iatrogenic small little defect resulting in bowel incarceration.
Yeah.
Now this one, just show this is a quick one that let me make sure I get the time frame right. I think this is just serves as a reminder that the complications still happen, and ICU radiographs, these are all done over the course of a few days. This was on the first. Guy's big heart in heart failure, and then a few days later he has some sort of code called, you can see he's rapidly intubated, and they placed a right internal jugular central venous catheter at the time. Of course, you know, we're underpenetrated. It's a portable, and for all the residents out there, just like I tell my residents, you know, everybody just goes to the left lower lobe trying to decide if there's atelectasis or not, and nobody cares about the lungs when you've got new devices in here. You got to make sure you see what's actually going on. And in this case, you might think this is a transvenous pacemaker. It's not. And you can see there's a subtle change in the thickness of this right here. Now, this was done overnight, so by the time they realized what had happened when the radiographs were being read the next day, it was already out. But this was a retained guide wire. And fortunately, it was still in the lumen of the catheter. But I think during all of the excitement of the code placing this, you know, these things occasionally happen. And you can see just a faint wire. This was the next radiograph done a couple of hours later, maybe this one, yeah. And I mean, this one, it would be impossible. It's still there because they haven't taken it out yet, but now they've even got an EKG lead right over that area. So there's no way to call it on this one. But on the other one, you know, you have to have a high index of suspicion. Just always think that this is one of the areas that we provide the most value on portable ICU radiographs. And then this was the next day, line out, wire came out with it. So patient was okay.
Just show us the wire again, Travis.
Sure.
Where is it again?
Yeah, so I think, I mean, the catheter must terminate somewhere right here, and then it loops in the enlarged right atrium, and I'm guessing it just goes into the right ventricle, because this patient has severe 4-chamber cardiomegaly, and there's pulsation, so there's a little bit of motion artifact here, but asymptomatic. I mean, in theory, sure, we've shown cases of these perforating the heart and leading to
valve too high. There's something odd about that, isn't there?
Yeah, that's true. I don't know. I mean, yeah, there was never any additional imaging besides radiographs, and the patient's fine now. Yeah, I don't know if the tricuspid valve is all of this area. You know, I don't know. It's a good point, though. You would think it might be a little bit lower, but we never had a lateral, and they realized their mistake before the patient came to harm. Okay, Jeff, I'll leave it at that.
All right. Thanks, everybody. Have a great rest of your week, a nice weekend, and we'll talk to you next week. It's nice seeing non-COVID cases.
Yep.
It's nice seeing things that aren't COVID-19. It's much more interesting now.
Agreed. Take care.
Bye, everybody.
Bye, everyone. Thank you.